Good afternoon, everyone, and thank you so much for joining us today. My name is Tiffany Rubalcaba, and I am the Associate Director of E-Learning here with the California Primary Care Association. And on behalf of CPCA, as well as the Partnership Health Plan of California and the National Center of Excellence for Eating Disorders, we'd like to welcome you to today's webinar. This is the third webinar in our Eating Disorders webinar series, and today we'll be focusing on the role of the behavioral health provider. So before we get started and I turn things over to our speaker today, I'm going to go over just a couple of announcements to make our time together more successful. You may have noticed that attendee phone lines are muted, and they will remain muted throughout our presentation. However, there are two ways you can submit questions or comments and engage with our speakers today. The first of which is by clicking that small radial button with the hand icon. If you click this button, it will raise your hand, and when we break for Q&A, I'll be more than happy to open up your individual phone line and let you know when you can present your question. Additionally, you can use that questions module there in the webinar toolbox on the right side of your screen. All questions chatted in will be received by me, and I will present your question on your behalf when we break for Q&A. You can also use the same question box to communicate to me any technical issues you might be dealing with, or if you have any other questions related to CPCA's other offerings, and I will chat directly back to you, so please be sure to monitor that throughout the session. We did email a copy of the handouts about an hour ago. So if you did not get that, however, they are available for download in the handout section for you now, and you can download them at any time before our webinar ends today. We want to thank you for registering for this webinar series. We do encourage you to visit our website at cpca.org to register for future trainings and events. And with that, I'd like to introduce to you our speaker today. Joining us is Dr. Jean Doak. She is Deputy Director of the National Center of Excellence for Eating Disorders. So, Jean, I'm going to go ahead and pass presenter control over to you now. You should see that button there to share your screen with us.
Thank you. Here we go. All right. And is that visible, Tiffany?
Perfect. Yes, go ahead. Thank you.
Great. Thank you so much, and thank you for the introduction, and thank you all for attending this webinar. I'm very excited to talk about the role of behavioral health providers, particularly around some strategies that could be utilized with patients who present with eating disorders. And so what I'd like to do is review the goals. I would like to say that I'm very well aware of the content that was presented in webinar 1 and webinar 2. Some of the information that I'll be reviewing today was presented in either or both of those webinars, and my intention in including it in today's webinar is just to demonstrate how the information ties into the behavioral interventions and the decisions that you'll be making in working with patients with eating disorders. So as far as the goals, I will just read them right off the screen, and we'll start with the top. We will review the criteria and goals of all levels of care for eating disorder treatment. We'll also identify targets for behavioral interventions, and that's probably going to be the crux of the webinar today. We'll also talk about how evidence-based eating disorder interventions could be adapted, particularly if you are working in a primary care setting or an outpatient clinic setting and may not necessarily have the expertise in working with patients with eating disorders. We'll address some very targeted strategies that could be utilized. We'll also talk very, very briefly about how to assist with co-occurring disorders, and probably more specifically, it will be how they interplay into how you make a decision about what level of care to utilize. And then we'll move on to navigating and referring patients to higher level of care, and then we'll have a brief discussion about the bi-directional referral process. So right off the bat, I do want to describe how you are primed to be in a position where you can identify eating disorders very, very, very quickly and very, very early. What we do know from the literature and what research has told us is that early detection is the key. The earlier one can be diagnosed, then the earlier one can receive treatment. And the earlier both those two things happen, the better the prognosis. It is very, very rare that patients take themselves or that families take their child directly to the emergency department or emergency room on their own because they're concerned. Usually there's some event that would lead them to go to the emergency room or emergency department. More often than not, it's their primary care physician who's made the recommendation that they go, or they may have some medical event, as I was saying earlier. Sometimes patients may get dizzy, lightheaded, or pass out, and often that's concerning enough to a patient or a family to go ahead and present to the ED or ER. But it's usually not for quote-unquote eating disorder symptoms. And so what I would like to do, Tiffany, if possible, I would like to just ask a quick polling question around levels of care, just so I can familiarize myself with what individuals are most familiar with.
Yes, awesome. So I do have that poll question open for everyone now. So those that are on an audio only connection, I will just read this to you. What level of care do you most often refer patients with an eating disorder? So there are 5 options: emergency room department, medical psychiatric inpatient, residential, or partial hospitalization or intensive outpatient, and lastly, outpatient. So I have seen about half of our audience has participated in the poll. If you have toggled out of the webinar, you can go ahead and come back in by clicking that blue daisy icon in your taskbar. And you can go ahead and submit your response by clicking in the radio button next to your answer. So we're going to leave that open for about 3 more seconds. Okay. So we have had 70% of the audience participate in the poll, so I'm going to close that now, and I'll share those results with everyone. So 7% indicated emergency room department, 20% indicated medical psychiatric inpatient, 4%, the lowest, indicated residential, 11% partial hospitalization or intensive outpatient, and 59%, the biggest group there, was outpatient. So thank you everyone for participating.
Yes, thank you very much, and that's very, very helpful. Although we will be talking and touching on those other higher levels of care, IOP, PHP, residential, and inpatient, the behavioral strategies that we'll address are really going to be targeted for strategies that you can incorporate on the outpatient level. So my hope is that that's going to be the most useful information for you. And so on that note, I would like to touch on screening for eating disorders. And again, my apologies that this may be repeated information, but I do just want to remind everyone, for those who've participated in previous webinars, that there are several screening options that you can utilize. The first one being SCOFF, which is a 5-question screener. The next one is binge eating disorder. And then the next one is eating disorder inventory, which is a bit longer. And then the other one is the National Eating Disorder Association has a screener that they list on their website. I believe all of these are publicly available. And so you can, again, this is just a screener. It's not a diagnostic tool, but it at least allows you to kind of begin to get the picture of a patient who's presenting with the possibility of an eating disorder. And then for the next step further, where you want to diagnose, yes, someone does have an eating disorder and you want to identify not only the diagnosis, but you also want to obtain some clarity and level of care. Following this process will allow you to do those things. So having a very, very detailed clinical interview. The eating disorder examination does walk through the clinical interview and eating disorder questions. And then the structural clinical interview for DSM-5 allows for further clarification. And then the eating disorder questionnaire that's listed at the bottom. This process, again, like I said, will allow you to obtain clarification that there is an eating disorder on board. It will assist in determining which symptomology the patient is struggling with, and that symptomology clarification will allow you to determine which eating disorder they may be struggling with. And then along with that, once you get some better clarification on the symptomology and level of distress, or to what degree it's interfering with their ability to function throughout their day, it'll help in determining what level of care would be the recommended level of care. And I will say, oftentimes, and I don't know if y'all have experienced this at all, sometimes the recommended level of care is not necessarily the level of care that a patient or family is open to. And again, when we talk about the strategies that you can utilize, we'll talk about how to try to get leverage in establishing that rapport with a patient and family and assisting them in being more open to whatever level of care is truly clinically indicated. So as you're working through that assessment process and you're considering symptomology and diagnosis, potentially also co-occurring disorders, the considerations that will also help you determine level of care will be medical stability. If there's any degree of medical compromise, that will be a great opportunity to partner with a primary care physician to determine if that level of compromise is easily manageable at the outpatient level of care, or if they would need more significant type of medical intervention or increased monitoring. You'll also consider the need for or amount of weight restoration. For some individuals, they've lost such a significant amount of weight that to expect them or their families to engage in the refeeding process all the way back up to their expected percent body weight range may be such a large burden for them to carry that they may need a bit of assistance from a higher level of care to get a jump start on that process. Also, you're going to be looking at to what degree their symptoms are interfering with their day-to-day functioning, like I mentioned earlier. If their symptoms are interfering with their ability to go to school, hold a job, in their personal life, again, you might want to think about what type of higher level of care may be needed. Age may or may not be a factor in determining level of care. Oftentimes, the literature indicates that for adolescents, ideally, given that the intervention is a family-based intervention, it would be most ideal for them to remain with the family. Again, if symptom severity is on board, you would have to kind of weigh the pros and cons in making that decision. Family involvement, always we want to encourage family involvement, friend involvement, some type of support system. The work of eating disorder treatment is so very difficult and challenging, and we all already know that motivation can be ambivalent at best. And so oftentimes if someone has a support system in place, it will make the treatment process a bit more manageable. And then, like I said, you're going to be looking at level of care. And so speaking of level of care, what I've done is I've made this very condensed cheat sheet version of the level of care criteria. Starting on the left in blue is outpatient, moving all the way up to the far right in red with inpatient. And notice those bi-directional arrows. You know, patients can move along the spectrum of level of care at any point in time in their treatment. But the main areas that you're going to be assessing will be medical, whether or not there's suicidal ideation, and if so, to what degree there's intention and plan. That category may determine a level of care that may have nothing to do with eating disorder treatment. If someone is suicidal with an active plan and intention to follow through with that, they may end up needing psychiatric hospitalization for stabilization before engaging in eating disorder treatment. You're going to be looking at weight status, as I mentioned in the previous slide. Motivation. I love that this is actually something to consider, because I did allude to how oftentimes motivation is ambivalent at best. This is something that can also wax and wane throughout the course of treatment. Co-occurring disorders. Oh, I should add, you know, I do have an asterisk in some of these areas, and the asterisks are listed down below. For suicidality, you're always going to be assessing suicidality and to what degree it's on board. And then for the co-occurring disorders, not only are you going to be assessing and diagnosing potentially what co-occurring disorder is in place, but you're also going to be assessing and have ongoing monitoring to what degree it interferes with their ability to fully take on or take in eating disorder treatment. And a quick example of that is if there's substance use or abuse on board. Oftentimes that we have found that with a substance use disorder, that is it can be so very disruptive and so treatment interfering that ends up being the focus of treatment versus eating disorder symptomology. And if you notice that a co-occurring disorder is interfering more so where eating disorder treatment is just not happening, they may need to step away from eating disorder treatment and address treatment that'll help manage the co-occurring disorder. It is not uncommon that we see patients who present with a substance abuse issue or diagnosis, and we will make a referral to receive substance abuse treatment before eating disorder treatment. It is also not uncommon that whenever we do make that referral, very few, if any, substance abuse treatment centers also have the ability or capacity to provide eating disorder treatment. And so we'll often get the call and they'll say, okay, this person has an eating disorder, we can't treat them. And we'll say, oh, this person has a substance abuse issue, we can't treat them. So this is where you're going to have to really hold firm and really have a firm grasp of your clinical justification as to why you're making that recommendation. You're going to be assessing the category of structure. How much structure is really needed for the patient to move through eating disorder treatment? The patient's ability to regulate eating disorder symptomology, exercise is an example, purging behaviors is an example. You'll also be assessing their environment, to what degree they have access to support and structure. And then geography. It is not uncommon, I'll just say in North Carolina, for example, there are 2 medical facilities who have teams with expertise with eating disorders. Those medical facilities are probably within about 20 or 30 minutes from each other. Meanwhile, we have the rest of the state that has no access to outpatient treatment or teams who do eating disorder work. And so when we think about what level of treatment is needed, we also need to take in geography. To what degree is a patient or family willing, able, have access to travel to receive treatment? Can we navigate some alternative mechanisms in which we can provide treatment at a distance, either through telemedicine or telehealth? So those are the broad categories that you'll be looking at as you're doing that diagnostic assessment and determining level of care. A couple of things to think about when you do think about level of care as well is that the higher levels of care present with challenges. It is not typical that patients or families say, yes, sign me up for the highest level of care. I want to be away from home and school and my family because I know how important treatment is. So oftentimes there is a lot of resistance there. With patients who are adolescents or even college students, obviously school plays a factor into this. Some states don't even have access to eating disorder treatment or eating disorder treatment at the higher level of care. So if you're making a recommendation, it may mean someone may have to travel out of state. There's often a bed shortage, and there's often, if not almost always, an issue with insurance. Sometimes insurance will cover treatment at lower levels of care, not higher levels of care, or some specific higher levels of care and not all levels of care. And that's assuming that a patient does indeed have health insurance. And then oftentimes what we find is that there are many providers out there, but there are providers who really just don't know how to work with patients with eating disorders or don't really know what the evidence-based treatment entails. So hopefully by the end of this webinar, I will give you some key strategies that you will use I will say there is not enough time to be able to train you in the strategies fully, but I'd like to impart some strategies that you'll be able to utilize in your clinic setting. So some structural barriers to treatment. I already referenced a couple of this, and there's actually, it looks like I referenced all of these already. So we're going to move on to the targets of treatment. And these targets are in place regardless of level of care. So it's one of the reasons why I wanted to make sure we review them. So under medical stabilization, which is a broad one, you're going to be looking at some of the comorbid issues that are on board due to eating disorder symptomology. For females, ideally, one of the target is the resumption of menses if they've lost their menses or have never had their menses. For males, probably the corollary is decreased testosterone due to malnourishment, and so you may need to partner with a PCP to get labs drawn to evaluate their testosterone levels. There's nutritional rehabilitation with weight restoration and the resumption of regular meal eating patterns. And then you're looking at normalization of eating behavior. So eating, I really try to avoid the word normal, but it would be more typical, where there are meals throughout the day and typically no more than about 3 to 4 hours in between meals and snacks. Then you're also targeting psychosocial stabilization. So again, always having an eye on the comorbid diagnoses, reestablishment into their social environment, improving overall psychological symptoms related to eating disorder symptomology, and then overall improved body image to the degree that body image no longer determines their behaviors. All right, so for treatment overview, this is where we're going to do some heavy lifting in the webinar. There are multiple treatments that there's evidence for, and so I do want to point out that the top two, enhanced cognitive behavioral therapy, CBTE for short, family-based treatment, FBT, are the two that we're going to be targeting as far as imparting strategies that y'all can utilize. There is strong evidence for each of these. For CBTE, the evidence is for use in adults. It was originally started or utilized with binge eating disorder, and there is now a self-help manual for binge eating disorder. It is also demonstrated to be effective with bulimia and anorexia in adults. And then for family-based treatment, the evidence is strongly in place for use with adolescents. So usually it's like 18 and still in high school living at home adolescents and their families. And the strongest evidence is for AN and their anorexia, and there's emerging evidence for bulimia as well. Dialectical behavioral therapy is often utilized, and oftentimes it's utilized for individuals who have difficulties with distress tolerance, emotional regulation. Oftentimes, if there's some non-suicidal self-injury involved, that could be a complementary therapy to assist with that. And acceptance commitment therapy, that is most often utilized with individuals who may be struggling with eating disorder and post-traumatic stress disorder. But again, for the purpose of this webinar, we're going to focus on CBTE and FBT. So why CBTE, aside from what I was indicating with the evidence? It is theory-driven as well. It is suitable for a wide range of adult patients, meaning like it is transdiagnostic. What we have found is that some individuals who present with one eating disorder may, over the course of their lifetime, present with a different eating disorder. So what I mean by that is some older patients who we see, we may be diagnosing them with binge eating disorder, yet perhaps 20 years prior when they were in college, they were struggling with anorexia. So we do know clinically, and as far as what the research has shown to us, that some individuals can move across the diagnostic spectrum. CBTE has also been found to be very acceptable to patients. There are multiple reasons for that, one of which is that they are very collaborative in the treatment process, and there is a lot of rapport that's established on the front end. The other thing that is also effective with CBTE is that it does come with a manual, so it is manualized treatment, and it's a prescribed treatment. So there are 20 sessions in total. And in the previous slide, I mentioned the transdiagnostic diagnostic process. And so this is an example of the transdiagnostic formulation. This is a model that you could utilize with patients. And so here, there's some psychoeducational opportunities that you can use with a patient, and you can use this to describe or to speculate or to wonder out loud if this is a typical pattern that they may experience. And theoretically, you can start anywhere in this formulation because you see where the arrows are. Oftentimes what individuals may say is, they start at the top and they say, I felt X amount of, I felt this way about my weight and my shape. And so therefore I thought the best thing I should do is to start cutting out carbs and cutting down my calories. And then they may find that they are undernourishing themselves and end up overeating and or binge eating at some point later. They feel some feelings of guilt and shame, and they engage in some compensatory behaviors, and they move back up, and then they can move all throughout that cycle. And then you could go down the right side of the arm of that formulation. The key in using this with patients is to have them use their own words, and then it becomes their formulation of how their eating disorders are perpetuated and maintained. And all the strategies that will be utilized, I often describe them as putting a wedge into this cycle. And it'll provide an opportunity for some relearning to be on board. As far as CBTE, this is the CBTE map, and these are the stages of CBTE that you could potentially walk a patient through or a patient will walk through. Obviously, starting at stage 1. This is where you get to stage 3 is where it is very, very unique and specific as far as what aspect really is key in their formulation. Remember, the formulation is just the previous slide. And so you can really have them identify and target which arm of stage 3 to work through. And then you work through stage 4, and stage 4 has a plan that we'll get to. So in stage 1, again, I'm not going to spend too much time talking about each of these stages, but I'm going to highlight some things that you can start doing in the clinic. Stage 1 is where you're doing a lot of heavy lifting as far as establishing rapport and developing that therapeutic relationship with a patient. Per the manual, it is 2 sessions a week for stage 1. It is not always conducive for a patient to come to a clinic 2 times a week. You are going to be demonstrating that you have some expertise in how CBTE works. You're going to be working on establishing trust. You're also going to be educating them on establishing weekly weight checks. You're going to be talking about the psychoeducation and the relation between weight and eating. You're also going to be prescribing regular eating patterns. So I mentioned earlier this notion of regular eating patterns. Regular eating patterns is where individuals eat 3 meals a day and 2 to 3 snacks a day with no more than 3 to 4 hours in between every meal and snack. And the idea, this came out of work in working with binge eating disorder. There is a pattern identified that many patients who struggle with an eating disorder can go for very, very, very long periods of time of food restriction, of no eating at all. And oftentimes that sets up a patient to engage in overeating patterns or binge eating patterns. And so research has demonstrated that if there's a regular pattern of eating, that disrupts or breaks down that cycle and reduces the propensity to engage in overeating or binge eating behaviors. And so patients will say, well, why do I have to do this? And then you can provide that psychoeducation as to why. The other thing that's important to talk about the weekly weighing and the weight checks, and I believe this was touched on potentially in webinar 2. These weight checks are typically unblinded weights, meaning that the patient can see their weight on the scale. If you are the provider who is going to be imparting the therapeutic strategies and interventions, it would absolutely make sense that the weight check is unblinded. You're being very, very transparent in the weight process. And right after the weight check, you'll be going to a room and talking about their response to seeing the weight, what their expectations were, and you're going to be moving through the strategies that you'll be utilizing. Where some providers choose to do a blinded weight is if the patient is going to be being weighed by someone who's not going to be working on these behavioral interventions, or someone who's not going to be checking in with them after the weight check about their emotional response to it, their expectations, etc. And so oftentimes in clinical practice, I find that that ends up being the decisional factor in using a blinded weight versus an unblinded weight. The other part that you're going to be educating the patient on is self-monitoring. And it's going to be very important as you work in establishing a wedge in that cycle that we were talking about earlier, that you have an understanding of what actually is happening every single day. And the self-monitoring basically is the patient writing down everything that they eat all throughout the day. And then you can look at the various columns. It would be the time, what they consumed. I often tell patients that the amount is less so of an issue. For example, I don't need them to measure their food. And for example, I would never want them to measure their food, so I don't need measurements on there. But I just need an idea of what they've eaten and what they had to drink, where they ate. The next column is whether or not they engaged in eating disorder behaviors. And then the third one is circumstances. I usually describe to patients that this is kind of like thoughts and feelings. I really want to get an idea of what all was going on before the meal, during the meal, and immediately after. And oftentimes we end up targeting that column quite a bit. I will add one side note. For individuals who struggle with binge eating disorder, or even who have binge eating episodes on board, say for example with bulimia, those patients considering filling out the self-monitoring record may also be accompanied with feelings of guilt and shame. It will be very, very important that you can name that up front, that could be a possibility, and it's very, very normal and typical. And again, as long as you understand the clinical rationale and justification, you can walk them through the process. Another side note is that oftentimes with younger patients, particularly college students, they are not super keen on using pencil and paper or pen and paper, and they want something that's more electronic. The CBT manual really encourages pencil and paper logging. However, if it really comes down to, they're going to do it or they're not going to do it, and the only way they're going to do it is if they use an electronic form, there are some records like recovery record that do have a mechanism by which they can log their behaviors. And then the regular weigh-ins. I put this up here as an opportunity to talk about the decisional balance between using blinded weights versus unblinded weights. So session 2, you are now down to once a week. And so the key strategy here is really jointly reviewing the progress of where they are after stage 1. And then you're also going to identify barriers to change. Here you always continually review their formulation and where they think they are in the process. And as you review the formulation, you're going to determine, remember in that CBT Map, there's that middle row of stage 3, like which factor is one of the factors that perpetuates their formulation. And that's what you're going to target. Stage 3, primary components. Again, you're going to either target shape and weight concerns, dietary restraint, or events, mood, and eating. Stage 4, these are the last couple of sessions. Here, you're going to address concerns about ending treatment, what their thoughts and feelings are about it. But more importantly, you're going to identify strategies to help them prevent or to help them manage setbacks. Setbacks are absolutely going to happen. You educate them that that's normative, it's to be expected, and you can plan accordingly. And if there is a setback, it's encouraged that they think about it within the context of a lapse versus a relapse. So if they do have a setback, it doesn't mean that they have to go all the way back to stage 1 and start the whole process over again. They have the skills and they can draw upon their skills at any point. Also within this stage, there will be a development of a long-term maintenance plan. And this is a great opportunity for them to list all the skills and strategies that they have found most effective for them. And they can incorporate that into the plan as they see fit. So that's kind of the quick review of CBTE. And I do want to say there will be a slide later that I'll review the strategies that can be utilized for CBTE and FBT that you could quickly utilize in the clinic setting, without being fully trained in CBTE or FBT. So moving on to FBT. I mentioned earlier that FBT is designed for adolescents 18 and younger living at home and living with their parents. It is designed to be an outpatient intervention, and so that's also important to consider. The primary goals of FBT will be weight restoration and symptom reduction, and then you're also further along into the FBT process. There is a goal to restore adolescent developmental status. The theory behind this is that whenever an eating disorder comes on board during adolescence, normal adolescent development gets interrupted. And so it's not uncommon that we may see an older adolescent who presents in clinic with a very, very strong eating disorder on board, and yet developmentally they kind of act or present as if they're a little bit younger, sometimes 14, 13, something like that. And it's not uncommon that they may present right around the developmental stage in which the eating disorder came on board and took over. There are opportunities within FBT to do a brief hospitalization if there's some medical compromise, but the idea is to make it as brief as possible so they can return back to their family so their family can impart FBT as soon as possible. Again, just like CBTE, FBT is manualized and it's a 20-session duration treatment. So the treatment style, this is something to get used to, but it's not too out of the norm. During the course of an eating disorder for a family's child, parents often forget that they fed their child all the way up to before the eating disorder came on board. And somehow the eating disorder has hijacked parent confidence and has made them question their ability about whether or not they can feed their child again. So the idea as a clinician is that you reiterate that the parents knew how to feed their child before the eating disorder came on board. They can indeed feed their child again. You're very much empowering the parents, and you're making very, very clear that they are the experts in their child. They may have lost, quote unquote, lost their child within the context of the eating disorder, but they truly are the experts of their children. The therapist stance is active but not authoritative, and very, very collaborative. There's a lot of deferring to the parents. And what I mean by that is it's less so about deferring the course of treatment and what strategies will be utilized, but more so about how they navigate using those strategies at home, how the parents decide what foods they'll serve, how much foods they serve, what kind of decisions they make at home in regard to their adolescent, whether within the context of the eating disorder or not. And you really establish that trust throughout this process. I did want to mention one thing earlier. Let's see. Oh yes, I'll address it in a slide that's coming up in a moment. Again, as far as the FBT style, the conceptualization really is, and this is something that happens a lot with parents, the conceptualization is that the eating disorder is not the parent's fault. I think in webinar 1 or 2, I don't remember, but there was an addressing of how the eating disorder is a biopsychosocial phenomenon. Again, this is an opportunity to re-educate parents on that process. You may have to educate parents over and over again on that. Oftentimes parents present with a great deal of guilt and shame and questioning themselves about what they did to bring the eating disorder onto their child. And oftentimes the answer is nothing. It is a combination of biology, psychology, and social factors. Again, one of the things that you need to reiterate is that food is their medicine. That is the only way, food is the only way that'll cure the eating disorder for their adolescent. Here again, the stance is the eating disorder is not an expression of family dysfunction. The eating disorder is an illness. Food is medicine, and the family is the solution. The family is in charge of dispensing the medicine. FBT is less so focused on family dynamics and problematic family dynamics. You're going to be focused less so about an uncle who's attending family dinners, often intoxicated, and what kind of impact it has on the family, et cetera, et cetera. It is very, very exclusively related to how the adolescent interfaces with their family and vice versa, and how the eating disorder behavior is going to be tackled with the strategies. Family is anyone involved. So oftentimes, we have less and less typical, quote unquote, typical families these days. So the family could be a grandmother and a father. The family could be an aunt and uncle instead of the parents. So anyone who is at home taking care of the child. So the phases of FBT there are 3 phases, phase 1, phase 2, phase 3. The goal of phase 1 is, again, I said this multiple times, putting the parents in charge of weight restoration and refeeding their child. Phase 2, this is a negotiation phase where parents gradually begin to think about transitioning control over eating back to the adolescent. It usually starts with something relatively small and then works up to larger and larger meals or snacks. And then phase 3, which is a very nice phase, is once the eating disorder symptomology is stabilized and the eating disorder is no longer controlling day-to-day functioning and activities, this is an opportunity to talk about adolescent development issues. So again, I'm briefly going to go through the phases and the sessions and really highlight some of the essential aspects in these areas. You have these slides. I know you can read them, but again, I'm just going to highlight some of the more important ones. In phase 1, session 1, one of the goals that you're going to do, and this is something that's literally in the manual, you're going to greet the family in a very sincere but grave manner. Sincere meaning you're going to be very honest, you're going to be happy to be working with them. Also, the grave manner is that there is an active eating disorder on board, and it's not to be taken lightly. Once an eating disorder can get on board, there's some significant medical compromise, psychological compromise as well, and it is a disorder that's associated with very high mortality. That is information that people need to be reminded of. It's so easy for people to forget that, and for people to think, oh, well, if he or she just eats, it'll be fine. And if he or she could just eat, then they probably wouldn't have an eating disorder. Here, the family story is, what was the family story before the eating disorder was on board? And what's been the family story after the eating disorder has been on board? Oftentimes, those stories are very, very different. And again, you're going to be charging the parents with the task of weight restoration and refeeding. Phase 1 also includes a family meal. This is where you really have them bring a meal into the clinic, and you have them eat in vivo, and you're going to share observations. Just like in CBTE, there are weight checks involved. And again, use the same decisional balance between blinded weights versus unblinded weights. But even with an adolescent, it really shouldn't be a secret that one of the goals is weight restoration if indeed they need to gain weight. One of the strategies utilized often in the family meal is the 1 more bite strategy. Just when the adolescent says that they can't eat anymore, you really encourage the parents to encourage them, the adolescent, to try to take 1 more bite. The remainder of phase 1, again, you're continuing to weigh the patient. You're going to support the parents in their work together. You're really, really going to emphasize that they truly are a team working against the eating disorder. And I say that very intentionally, against the eating disorder, because one of the other strategies that you utilize in FBT is you externalize the eating disorder from the patient. Oftentimes patients will say, I'm my eating disorder is me. And that is not the case. They existed before the eating disorder. They can exist after the eating disorder. And you can often refer to the eating disorder either in third person or third voice, but it's very, very critical to externalize the illness. So some guidelines as you transition, there's some weight criteria, there's some observations around the adolescent's ability to eat, and also parents reporting of how they feel that they're managing the illness. And in phase 2, again, you're continuing to weigh the patient. But again, as I mentioned in the one slide with the 3 arrows shifting down, in phase 2, a lot of the work is going to be the navigation of transitioning control over eating to the adolescent. And it's a little bit of a give and take and a little bit of trial and error. Again, some guidelines for transitioning to phase 3, which again is the final phase. So there's weight criteria and also to what degree they're engaging in eating disorder behavior. And then in phase 3, you get the opportunity to talk about normal adolescent development. And so those are the strategies for FBT. So what I'd like to do, and I referenced this earlier, I put kind of all the strategies within FBT and CBTE that you could utilize in an outpatient setting without being trained in either one. Again, it is very, very important in working with patients who present with an eating disorder that you work collaboratively with a team. Even with FBT parents being in charge, there's still a team who's working with the patient, and various disciplines can be involved in the team. The key concepts with all of these, well, with these 2 treatments that we talked about, one is the collaborative weight checks. It is not beneficial to the patient in any way that weight stabilization and or weight gain is a secret. That's not a collaborative treatment process. Again, there is an opportunity to use that decisional balance about whether or not weight checks are blinded or unblinded, contingent on who is actually doing the weight check. Reestablishment of a regular eating pattern and self-monitoring. The self-monitoring is really just for adults. Within FBT, it's really the parent's observation that, quote unquote, serves as a self-monitoring. You don't have the adolescent or parents write down or complete a self-monitoring record. Family is in charge of refeeding for adolescents. Again, externalizing the eating disorder. This is very, very beneficial within FBT and CBTE. There's an ongoing review of treatment goals. Remember, like all those categories to assist in determining level of care, you're going to be reviewing that all the time. In CBTE, you're going to be reviewing the patient's formulation map all the time. You're going to be reiterating what the goals of treatment are, how they're feeling about the goals, what kind of progress they're making. Always, always keeping an eye on motivation, knowing that it waxes and wanes throughout treatment. And then one particular comment that I didn't address in CBTE or FBT is that with college students who are away from family at home, it is not uncommon to use college contracts. And it could have, I don't think there's enough time to talk about it, but college contracts can be in place where there's a mapping out of treatment goals and targets in order for the patient's treatment team and family to be okay with the patients either being on campus or the need for them to return home for treatment. And then, as always, involving family and the support system. Some step care approaches, and this is super helpful with patients who don't have easy access to a clinic. I mentioned earlier telehealth and telemedicine. There's some mobile apps that I'll show in just a moment. I also mentioned some self-help interventions, and I'll show you a slide related to that. And then, given that patients don't often present for their initial clinic visit with a therapist or behavioral health specialist, you can use some other discipline as establishing an inroad. If they've worked with a registered dietitian before or their PCP, you can partner with those providers to establish an opportunity to get an inroad. So mobile apps. This one is helpful for binge eating disorder. And so you have these slides, so I know you'll be able to access that website at some point later. SelfHelp Resources, I mentioned overcoming binge eating disorder. Chris Fairburn developed that, and it is within the model of CBTE. There's another self-help resource listed as well by Dr. Bulick. Now, I mentioned multiple times that there's no opportunity to provide training in CBTE or FBT in this webinar. And so even just reviewing the strategies is not a substitute for the training. And having said all that, I wanted to at least give you access to where you could get the training if you were interested. Right now, CBTE training is free, which is great. It's a wonderful opportunity. Oxford University has a grant from the UK that is allowing for the training to be free for now. I don't know how much longer that will be in existence, that it's free, but that's a great opportunity to capitalize on. FBT training is not free. However, here's a website if you're interested in obtaining training for FBT. Additional resources for yourself and family. FEAST is a great one to utilize within the context of FBT. FEAST stands for Families Empowered and Supporting Treatment of Eating Disorders. And then the Academy for Eating Disorders has some great resources. They have webinars, they have tweet chats. I believe they also have book reviews available as well. So there's some information from them. And of course, National Center of Excellence for Eating Disorders, we have a resource library. We also have a training center where this webinar and other webinars that we've done are and will be uploaded. If you're wanting up-to-date information, evidence-based information from one spot, you can check out our resource center and find all sorts of information that could be helpful to you. And then finally, I included some references that it's related to the content that we addressed in the webinar. And then the final slide is for questions. So I hope I saved about 10 minutes or so for question and answer.
Sounds great. Yes, thank you very much. All right, so I currently have 3 questions in the queue. Just really quickly, if you have a question, you can click that radial button with the hand icon. I can open your phone line, or you can chat in your question using the question module on the right side of your screen. So first question, in FBT, does feeding mean preparing and plating, or does feeding mean actually putting food to the child's mouth?
That is a great question. And so in its more fundamental form, it does mean food prep, meal prep, plating the food. I apologize, you may hear my dog barking. I am doing this webinar from home because we have a snow day, and so I am not able to be on campus. So my apologies for that. It does mean that the parents plate the food, prep the food, and sit with their child during the course of eating. In very, very rare instances, it does mean feeding the child. If that's what it takes for the child to eat in that moment, that's fine. Just having an understanding that's not the ultimate goal. The other thing about the meal is that we really train parents to wait it out. So this can be very disruptive for the family system for day-to-day activities, but if their child is sitting at the table refusing to eat, and 30 minutes goes by and they still have half of their food on the plate, the parents set the expectation. You will take one more bite. We are not going to leave the table until you take one more bite. It's one of the reasons why FBT is really utilized with adolescents and not adults, because parents have more leverage with adolescents than they do with an adult child. And so that's something to consider. And then the FBT manual goes into detail about various strategies that parents can utilize whenever they encounter their child being very resistant to eat the food.
Great. CBTE appears to be extremely time limited. Can you comment on its use for clients who are stepping down from higher levels of care or who may not be ready to terminate care after the 20 sessions?
Yeah, I will address the first one first. You know, it's tricky to start with actually either FBT or CBTE when someone is stepping down from higher level of care, because the way both of those are designed, again, ideal for outpatient treatment, and the first stages or phases are within the context of the patient not having received treatment before. So you may have to think about like how you make adjustments, and you may need to consider what skills they received at those higher levels of care, what were some of the barriers that they encountered in receiving those skills, what were challenges, what were things that were easy and what were things that were not easy. So you may have to kind of get that baseline information and then figure out where it would fit within the context of starting CBTE. As far as the termination process, ideally we want patients to finish treatment, complete treatment, and move on and have wonderful lives outside of treatment. And what we find often is that patients are really scared and they'll say, I don't know if I'm ready to end this. And usually patients have been struggling with eating disorder thoughts and behaviors and symptoms for years. So to think about that they're going to be done in 20 sessions can be overwhelming. That's where you really work on that relapse prevention plan. You provide a lot of reassurance. I also have had patients transition out of CBTE and more so maybe into CBT. So meaning like they may have completed CBTE, but they're just not ready to terminate therapy per se, and they want to talk about quality of life and returning to a life outside of the context of an eating disorder, having a life worth living. What does it look like? How they build their life. So you can transition treatment to be more focused on that and less so the manualized CBTE.
All right. How can the FBT style be used with youth residing with foster parents or other caregivers who may not have fed the youth as a young child?
Yeah, that is tricky, and it is a judgment call. It may require some one-on-one meeting with the foster parent. Oftentimes in our clinic, we have provided the opportunity for a parent, a foster parent, adoptive parent, or an aunt to meet with a dietitian to just review like what would be expected for a child of this age, height, and with a percentage of expected body weight. How do they know what's normal? And so there's some psychoeducational opportunities related to that. Also, sometimes with some foster situations, they don't know how long they're going to be with the child. So if there are more and more of those kind of unknown variables, you may need to consider if whether or not FBT is really the right strategy to utilize. Or you may need to decide, okay, we're not going to be able to do manualized treatment, but we can include some aspects of the treatment that the foster parent can utilize. For some older adolescents in that type of situation, like some 16, 17-year-olds who are either emancipated or have moved around from foster home to foster home, we may end up using CBTE rather than FBT.
What was the medical target of treatment? Is it resumption of menses and increased or decreased testosterone?
I think I know what slide, and I remember having that, making that comment. One of the markers of medical stability in females is a return to having a menstrual period. So if a female had a menstrual period before the eating disorder and somewhere along the way, due to undernourishment or malnutrition, they lost their menstrual period, one marker of stability is the resumption of or the return of their menstrual period. I do want to add one caveat in that some patients do present with primary amenorrhea, meaning that they've are yet to have their period. Sometimes it is a bit delayed due to malnutrition. So that would be partnering with a PCP to establish what that medical marker would be, given that they had never had a period before. So it's a marker that's used to determine medical stability. And the corollary for males would be having testosterone levels that would be considered in the normal range.
Have you seen primary care clinics with integrated behavioral health teams treat eating disorders with one of the modalities you mentioned successfully, given our brief session?
Yes, it can happen, and sometimes those clinics are a bit more specialized, so it might be a pediatric clinic, or even a pediatric clinic that has a adolescent medicine component, where the providers are trained in adolescent development and in these interventions. It can be done, I will say, for, no, that was for CBT. For CBTE, like if you're working with an older adolescent, having them come to a clinic 2 times a week in that first stage can be a challenge. And oftentimes, depending on insurance status, there may be some pushback. So this is where having clinical documentation justifying the rationale is going to be really key and critical.
All right, so that brought us to the last question in queue, and we're pretty much right on time. So given that, I want to just take an opportunity to thank you, Dr. Doak, for this very informative presentation. I'm sure it is extremely valuable in the course of the other webinars that we have had. I want to also thank our audience for their participation today. Really appreciate everyone's engagement and the questions. And just a couple of announcements. We did record today's session. You will receive a link to the recording as soon as it becomes available. And I do want to also highlight the importance of completing a brief survey that was provided to you all via email. I think half of our registrants have completed that survey, but we are really hoping to get 100% participation. So really appreciate you taking the time to take care of that before we end our last session, which is coming up. So with that, I want to just thank everyone once again and wish you all a wonderful afternoon.
Thank you, Tiffany, and thank you all for participating in the webinar.
Great, thank you.
Thank you.